So hi, everyone. Welcome to the day one of our annual Stanford Synapse Brain Injury Conference. We are incredibly excited that you're here, and we have an amazing lineup of speakers and panelists who you'll be able to hear from and ask questions to over these next few days. My name is Gabby Lee, and I'm currently serving as Stanford Synapse's president. Stanford Synapse is a wonderful student group that supports individuals with brain injuries through fostering a strong social support network and creating a community of advocates. We facilitate weekly peer support groups for people with brain injury, organize the GLEAL program, which pairs students with brain injury individuals, and for one-on-one companionships. And we also host events to raise awareness about brain injury. The goal of this conference is to learn more and raise awareness about brain injury through the perspectives of clinical care, policy, biotech, and lived experiences. Also, I'd like to give a special thank you to the Department of Medicine, Neurology, Neurosurgery, Psychiatry, and Behavioral Science, and the Vice Provost for Undergraduate Education for sponsoring this event. Without further ado, I'll pass it off to our conference committee to introduce themselves and get the show on the road.
Hi, everyone. I'm Kobe. I'm a non-traditional student from Philadelphia, completing my bachelor's degree in human biology before doing my pre-medical degree, master's degree next year in biology. I have a very strong interest in emergency medicine, of which TBI is especially important to consider, because the brain is such a precious organ. And I look forward to moderating the career panel later and helping to facilitate a smooth experience throughout the conference.
Hello, everyone. I'm Bakal. I am from Dallas, Texas. I'm a freshman student interested in both biochemistry and computer science. And I'll pass it off to Zoha.
Hi, everyone. I'm Zoha. I am a sophomore interested in psychology and human biology, and I am from Pakistan. I am going to be passing it on to Dean.
Hey, everyone. I'm Dean. I'm a first-year student here. I'm from Morgan Hill, California, so like an hour south of Stanford. And I'll pass it on to Julia.
Hi, I'm Julia. I'm a senior and I'm from Houston, Texas. I'm VP of Conference Committee, and we're going to be moderating the event over the next 3 days together. We're really excited to have all of you guys here, and we've really enjoyed putting the conference together, and we're hoping that it'll be a great way to connect brain injury experts with the Stanford community and with brain injury communities. And even though this year looks a lot different with the conference having to be remote, we have a great group of speakers coming, and we're also excited to have the opportunity to welcome speakers from different parts of the country, as well as audience members from different parts of the country. And regarding the format, like Gabby said, today will be focused on perspectives from clinical care, tomorrow will be policy oriented, and Saturday will be biotech. And today we're having two speakers giving talks, David Entwistle and Dr. Ghajar, and that will be followed by a career panel. So it'll be a total of about an hour and 45 minutes today. And regarding how this will work on Zoom, we just have a couple of guidelines for you guys. So I'm gonna share my screen briefly. So first, try to stay muted during the presentations, and also we'll have built-in time at the end of each speaker's talk to take some questions, at least for 5 to 10 minutes. So during that time, you can either use the raise your hand feature and we'll call on you, or you can also type questions into the chat and we'll select a couple of those to read to the speaker once they're done giving their talk. And finally, if you fill out the attendance sheet that we're gonna continue sending in the chat, we'll send out a $15 DoorDash credit to the first 100 people who fill out that form. It'll be delivered to your email address sometime next week. And for anyone who doesn't know, DoorDash is a food delivery service and they work with a lot of restaurants. So if you fill that out and you make a DoorDash account, then you'll be able to get $15 off on your food. So now I'll pass it off to Dean to introduce our first speaker, David Entwistle.
Thanks, Julia. So our first speaker is Mr. David Entwistle. David Entwistle is the president and CEO of Stanford Healthcare. Before joining Stanford Healthcare, he served for 9 years as CEO of the University of Utah Hospital and Clinics. He also previously served as a senior vice president and chief operating officer at the University of Wisconsin Hospital and Clinics in Madison, Wisconsin, and as a vice president of professional services and joint venture operations at the City of Hope National Medical Center in Duarte, California. As a recognized healthcare thought leader, Mr. Entwistle serves on the boards of the American Hospital Association, the AAMC Council of Teaching Hospitals, the Accreditation Council for Graduate Medical Education, and Vizient. He is the past chair of the Utah Hospital Association and was appointed by the governor of Utah to the state's Medicaid task force. We're extremely excited to have him here today, and without further ado, I'll hand it off to Mr. Entwistle.
Well, Dean, thank you. And let me just first off say, I really appreciate the Synapse conference inviting me to be here today. I am a TBI survivor, and so I'm going to give a little perspective on that. I'd also like to thank you, and I love just watching the chat and seeing individuals join from around the country. In fact, many of you, like me, are a TBI survivor, and so you certainly have a perspective. And I hope that, again, some of the thoughts that I share will you'll gain a little bit from, but then also those who are potentially either going to be caregivers or even supportive of individuals with TBI, I hope that they too garner a little bit from it. And hopefully we'll get a little bit of time for questions as well. So what I'd like to do, let me go through a little bit of a description of what as I call it, my crash. I'll talk a little about my recovery, kind of what I went through. I also want to talk a little about what my family was going through, kind of why I was, as I say, blissfully unaware in the bed, trying to recover from this, what they were having, a little bit about what the recovery process is. And then I'll talk hopefully a bit about what is life after the recovery. As you probably know, TBI is a long recovery, and it's something that, in fact, sticks with you for some time. And then also, I want to close with just kind of the importance of some of the relationships that I had, especially going through this process. So hopefully we can touch on something that will be of interest to you. And I just, again, I will start by saying I appreciate all of you joining us, literally from around the country. Well, again, I will say my crash was a little bit of a unique occasion for me because since I had been born, I had not been in a hospital as a patient. So when I went through my crash and then landed in the hospital for literally almost 4 weeks of recovery, here I am, a CEO of a hospital system without ever having the experience from being from that side of the bed. Unfortunately, a good portion of that I actually don't remember because, again, in terms of what I was going through and the experiences that I had, I don't have the recall of that. And I have to tell you, that is something weird. Could you imagine literally having a week of your life just gone? You don't remember it. There's no experience. I don't remember the crash. I don't remember some of the recovery. In fact, my wife tells me about some of the things I was doing during my hospital stay, and I'm like, no, I'm sure I didn't do that. So she also told me about a few of the things that I promised her while we were in there and I said, no, yeah, probably not that either. I'm kidding. She didn't say that, but sometimes you wonder. But let me just tell you a little bit about my crash. I was actually, and I've probably done 50 plus triathlons. I've done full distance Ironman where you run the, long swims, long bikes, and then run a marathon at the end. I've done a lot of these. So this was something that was in the cadence of my experience. But literally, I was in a place called Stansbury Park, which is by Tooele, Utah. I doubt that any of you have ever been or heard of Tooele, Utah. In fact, it's usually people pronounce it Thule, so it's the way it's spelled. So it's a unique place, but they were having a great triathlon, Olympic distance. Literally, I remember being on the bike. I was about 23 miles into the bike and thinking to myself, okay, I've got to make a quick transition and jump into my 10K run. That's it. That's the end of my memory. In fact, the only thing I can do, I can go back to my Garmin, which was my little bike computer on the bike, and I can see that I was going 23.4 miles an hour and went to 0 in about a foot. But other than that, I have no idea, no recollection of the crash. I could look at the bike and kind of see what happened. We think what happened is I reached over and grabbed the front left brake, which, as you know, is the front rim, and probably I just went over and landed on my head. In fact, I still have the helmet that I was wearing. I keep it as a souvenir. It was basically caved in on one side, but that was the last, I have no memory of that other than thinking to myself what I just shared. And so that's what's challenging about a brain injury, is many times the recall is not there, you don't understand what happened, but yet what occurs after certainly is the long recovery. I was fortunately, there must have been people along the route that picked me up. In fact, I found out later, in fact, there was a patient that landed back in the hospital who made the comment. He says, "Is there any way I could meet the CEO while they were patient in the hospital?" And so, of course, the message got to me, and I went up, and he actually said, "I was actually the person that found you first on the road." He goes, "I'm a paramedic, and my dad and I were going fishing, and we found you there on the road. There were other racers that were going by but he was able to stop and get things initiated with me getting to the hospital." Fortunately, I was sent to a local hospital. They quickly did what would be the course in doing a CT scan. And also the attending in Kobe, I think you shared going in emergency medicine. Fortunately, the physician had been trained at an academic medical center. After looking at the CT, pretty quickly determined, okay, this is a traumatic brain injury. It's above what this community hospital can deal with. And so I was actually put on a air flight back to my own hospital, the University of Utah. Now, interestingly enough, if you know what a triathlon is, the only markings that I had on my body were the numbers that were written on the side of my arm and legs. And so nobody knew who I was. And in fact, it was when the air medical team arrived and realized, this is our CEO of the hospital, that was the first time that kind of went into that. And that was when part of the messaging got back, and my wife was called, and others on the trauma team at University of Utah were called. And so folks were ready when I landed. I will say that's a little disconcerting when the paramedics called my wife at home and they said, "Oh, this is the air medical team. We have your husband. We're taking him to the University of Utah." And my wife thought at first, is this a joke? And so, sometimes you surprise your individuals when we've got these traumatic events. And so always take those calls that you get in stride in terms of what's going on. I quickly got to University of Utah. They assessed where I was at, the TBI, and there were some things that they had to do kind of immediately. One was they had to put a stent basically in my head. And I can tell you one of the traumatic experiences with my wife is them coming in saying, "We need to shave your husband's head." And my wife was, a little stressed about that, not kind of knowing what all was going on. One of the nurses, though, I will say, was very attuned to that and kind of the stress my wife was going through, and said, "Well, doctor, could we just shave a portion of his head? We have to shave his whole head." So that was helpful. And I will tell you that the caregivers go a long way in terms of what the patient, but more importantly, some of their families are going through. And so that was kind of my encounter. That was what I ended up going through in terms of that. And I will say, having those resources at the hospital, having those individuals that can quickly assess what's going on, realizing that this is a TBI, and being able to react quickly to that is important. So at the hospital, what happened, I spent about a week in the ICU. I slowly regained cognition, but I did not really know what was going on. I will say that I wasn't really conscious. Even though I was talking with my family, I could recognize my family. In fact, I have a wonderful son who was at the time about 8 years old, who came in the room, and I immediately recognized and said my son's name, Chase. But really for about a week, my ability to kind of remember any of that really isn't there. And so my first real memory was when I woke up about a week later in the rehab hospital. And I woke up kind of, I hate to say, I thought that whole time I had been on a business trip in Arizona when I woke up. Now, why was I thinking a business trip in Arizona? I have to admit, that's probably not the most exciting thing I was probably thinking about during that week. I probably could have picked something better like Hawaii or something like that, but it was a business trip in Arizona. So I went through that, and woke up, I couldn't move my right leg. That obviously caused a bit of concern. And in fact, my physician, who was the neurologist at the time, wonderful lady. In fact, we had worked on many projects before. Dr. Elaine Scalabrand. She came in, and in fact, the first thing she said to me as I'm sitting there in the bed is, David, if you hadn't been wearing a helmet, you'd be dead. And I thought, okay, thanks, Elaine. Great to see you as well. But I have to say that was very meaningful to me because she recognized the importance of what I had been through, and more importantly, the fact that if I had not had a helmet, I would not have had the outcome of being sitting there in that bed. And that was very meaningful to me. I will share that, the discussions that my family was having while I was there in the bed, those are hard. And if you have somebody that you have worked with who's been a family member who's had a TBI or a friend, there's a lot of unknowns with TBI. And I'll tell you, my wife was struggling because my wife's parents were there. They were trying to figure out what was going on. And there's a lot of information. You don't always know necessarily, the physicians would tell my wife, they were like, if he recognizes you, if he can actually have the ability to have the cognition and the memory of what was happening before, where he's at, whether his movement will actually occur. And I think from the standpoint of the physicians, what I loved is they actually give kind of the honest truth of kind of what's happening so you can prepare for the worst. But for the family members, as you may know or have seen, that's stressful. And so as we talk about with caregivers, even with our nurses and our social workers, my wife and I went and spoke with them before just about how do you make sure that you're doing some of the things that are supportive of those that are dealing with the stress of being there and having to deal with that. I will say the recovery process is slow, and sometimes that's probably one of the most challenging processes. And my neurologist told me that. He goes, you got to be patient with this. This is something that is not going to come back easy. Basically the brain being able to reconnect. I kind of described it as being in a fog. You kind of have a fog over what you're doing, what you're thinking, what you're acting like. And that's tough to shake. And I think that's something that is something that it's hard for people to understand what it is. I will say that I also learned firsthand what the value of empathy was in healthcare, because it was humbling feeling that I was vulnerable. I was unable to sometimes articulate kind of what was important to me. And in fact, some of the things that were most valued to me, I couldn't do at the time. And I think that's a tough goal. Now, fortunately, I had a great PT, OT, and speech therapist that worked with me very resiliently. And I have to tell you, setting goals was an important aspect of what PT did. And so if you ever think about somebody struggling with this or going through this or what you could do, helping them focus on what's next. And I remember sitting out there, I was looking up at the side of the hill as I was sitting in my rehab bed. And I happened at that point to see a runner go jogging by. And I remember thinking, I don't know if I'm ever going to be able to do that again, but I'm going to set a goal for myself that I'm going to do that before I get out of here. And in fact, as I was in rehab, and that was one of the things that my PT challenged me, is to say, you've got to get out, you've got to get up, and you've got to get moving. And so that was able to be a goal for mine. And in fact, through multiple weeks in the rehab hospital and through multiple failed attempts, through some hard work, I was able to get out of there. And in fact, on the last day, my therapist said, we're going to fulfill the goal that you set at the very beginning. And we went up there and we actually ran on the side of the hill. Now, I have to say, I didn't go very far and I felt like I was out of shape already, but it was something that was accomplished. And so as you think about setting those goals and priorities for individuals, that's an important aspect of that. I will share, there's life after recovery. I went home. I was home for probably about 3 months. I will say it was a hard road. I probably tried to get back into my CEO job too quickly. In fact, we were opening a brand new hospital there. In fact, the picture you see behind me is the new hospital we have here on campus. But that was motivator. I think for me, with my own style, it was nice to have something that I was working on and doing. And so thinking about what those individuals are, either those that are recovering, those who have had those challenges, what are the things that motivate you? What are the things that would motivate them in terms of where they're going? And I think that's, again, back for me, as I was sharing, it's a humbling experience because you really kind of are challenged by what you can do, what you know you're going to have, and kind of how quickly that's all going to come back. I will say maybe I was a little ambitious. My goal for the first year of my recovery was that I said, I want to run a full course Ironman. And so literally one of the things that I had done that before, and I said, if I can do that again, I'll know for my own self mentally I've achieved. So I have to tell you, my wife was not excited about that because she's thinking, well, isn't this what got you into this challenge? You know, but she said, if that's something you love, that's something I'll support that you do. And in fact, I had the pleasure of a year after my accident, completing one of those, the Ironman. And so it was something that brought about some, personally, some not only recovery for me, but also the ability to kind of think and move on. And so what are those things that will be important for you? I will say that relationships were an important aspect of this. And it's hard to be patient. And I think with individuals that are going through this recovery, as I was talking about the fog, whether that's the fog that you're dealing with, whether that's physical challenges that you're dealing with, it's hard to be patient to go through those, not only as an individual, but as individuals that are working with you as well. And I would just say, be patient, work with them, have the opportunities you can to be a supportive network, because that supportive network was so key to being able to get on the other end of this and seeing that. It was probably about 6 months before, and I kind of say before I felt like things really were starting to connect back in the brain, so to speak. But it was a full year into that recovery before I felt like I was completely back to kind of myself. In fact, it was a very meaningful moment for me when my son, who I was talking about, he was about 9 at the time. I was in one night tucking him into bed, and we'd finished up what we were doing to kind of get prepared. He climbs into bed and he looks at me, and he made the statement. He goes, "Dad," he goes, "it's great to have you back." And I have to tell you, for me, that was one of the most meaningful things, because he was starting to see that Dad's kind of back to his old self, or was back to the dad that he recognized before. And so that's a hard road to go down. It's hard to put your family through that, but also to see that there is life on the other side of that. Now, I know my recovery is not the same as everyone's recovery, and I've had the opportunity to talk to many TBI survivors around the country. And again, I'm very fortunate for where I ended up, and that's not always the case for everyone. And there's a lot of challenges that individuals deal with. But having someone there to help goes such a long way, and I think is an important reminder for me about how grateful I am for that. Now, I will tell you that I've got to put in a couple plugs, because one of the things that was very important for me is, are you that person that's helping? Are you the person that's reaching out to them? Are you the person that's going to be that support for them? And I would say taking that opportunity to do that, or to learn how you might be a better caregiver, how you might better be able to support, goes a long way. And so I appreciate this conference being able to do this. As I shared, in many ways, I'm lucky, but the reason I was lucky, and I still come back to Dr. Scalabrand saying, wear your bike helmet. I cannot be a stronger advocate for doing that, because one of the ways that we can protect our brain is really that ability. So I will not get on a bike. I won't even ride it around in my driveway without putting a helmet on. It's one of those things that's so important to me. And whether some of the other things that I do, whether it's ice climbing, snowmobiling, some of the fun things that I get involved with, the helmet is so critical for that, just to make sure that you have, and you just don't know what's going to happen. And so being an advocate for brain injury prevention is making sure that we at the same time are wearing our helmets. And I hope, and I love the fact that the group actually, and I hear we'll do this again next year, is have helmets available actually for individuals, and the more advocacy that we can do for that, I would appreciate. So I appreciate being here with you today, and happy to take some questions on either my experience, what I've been through, what we're talking about, but I'm happy to be able to share just a few thoughts.
Thank you, Mr. Entwistle. And if you guys have any questions, feel free to send a message to me in the Zoom chat, or you can use the raise hand feature in the participants tab, and I can call on you. So, Mr. Entwistle, we have one question here that says, has your experience with TBI affected how you view TBI in healthcare? And what would you say is the biggest challenge in dealing with it?
I think certainly, one of the experiences that I had, and I think I shared, is, not being in a hospital bed. There's a different experience you have on being on the other side of the bed. I mean, and being able to have that education and awareness. Now, this was a hard way to do it, but it has changed the way that I lead. It's changed the way in terms of what I look at, what we do to support our patients, the quality of care that we provide. All of that has a different meaning for me. And so more than anything, I think part of that has been to create awareness around what can we do to prevent this. A lot of times when we see the patients that come into the emergency department, or quite frankly, in my case, like I did get transferred from another hospital in, it's usually a traumatic event, certainly something they were not anticipating or not going through. And so what can we do internally, whether that's our social work resources, whether that's resources for our families, whether that's the caregivers' support and learning about how do they provide the best care. I'll have to tell you, when I woke up, it was interesting because I had all of these bruises on my chest. And I was like, where did these come from? That was kind of interesting, but I learned quickly that that was what they do to pinch you to try to create awareness. And so what are those things that we can do to educate, support, help people better realize some of the things that are part of that process and part of that healing? And that really has been, I think, what we have been able to change. And then more importantly, just some of the proactive efforts that we've done for injury prevention.
Yeah. Jason says, thank you for sharing. And the part about your son and the moment you guys shared was very touching. Yeah. Kimberly asks, how do you feel about the importance of touch while a person is waking up? Meaning, I would have loved to feel someone holding my hand eat while I wake up in a different world.
Yeah, I have to say, and I literally clearly remember I was sitting in the bed. It was kind of like the light went on and I could see my body. I could see over the bed. I don't know that, in fact, I was there for a week in the ICU that I have no memory of. And again, I was talking, I was conversing, I was interacting with but I literally don't know anything that was going on during that process. Human touch is always an important thing. And again, how that might have impacted me during that process, I just don't have any cognition of it or that experience. But certainly I think that's a powerful example of something that we can do as caregivers, is to be able to have that touch. It's a great piece.
Yeah. Ken Collins has a question. You can unmute, Ken.
Okay, thank you, Dean. Well, fantastic presentation. We have so many similarities. It's really amazing. I guess one of the questions that I've had, and I've heard this a lot from different people, and I've heard this, I've seen this myself, about why do doctors and professionals give the worst case scenario? I mean, one of the things that I know what was a driving force in my recovery was hope. I could see that I was getting better, but it seems like it would be more helpful if doctors and professionals would just say, hey, I'm not sure what's going to happen, but I'm here with you to all along the way as we figure it out. Instead of telling somebody, oh, you're never going to walk again, you're never going to do your, all the negative stuff, because I've seen that really hold people back. And can you talk a little bit about that?
I'm not a physician myself, and I don't want to lay this on Dr. Ghajar, who's going to speak next, but he might have some insight on that. I will tell you, though, on both sides of the story, and I do think it's also good for family members to be aware of what could happen. I will say, when I woke up, I mean, it was nice that I had the cognition. It was nice that I could walk again, but I don't know that everybody has that same experience. And so I do think there's a little bit of prep that goes into that for the family members. Now, if that's the right approach or not, I don't know that because you don't want to be to the point where you get them to the point where they don't have the hope. And that's an important aspect, as I talked about, having that hope of doing the next thing, the next goal, the next stability, and seeing progress into that. If I hadn't had that foundation, I don't know that I would have recovered probably as quickly I had, or may not have recovered as much as all. So I like your point, Ken, that I do think that hope aspect is an important aspect of that.
Yeah, thank you.
Yeah, and unfortunately, we only have time for one last question. Jason asked, did you have any issues with others not understanding what we TBI survivors are going through? To me, that is one of the hardest things.
Absolutely. Oh my goodness. So the hard part is, again, once my hair grew back, so that was, I had the shaved head and back, but here I was back at work, and people don't know because they look at you on the outside. Again, I'd been through this bike accident, been in the ICU, been in the rehab hospital. I was back at work. I looked normal, and people don't understand, and when I went back to work, as I said, I went back pretty quickly. I pretty quickly found out, hey, I can't do a full day. In fact, I had to cut back, and in fact, worked at home for about a month because I'm going, okay, I was overdoing it. And then even when I got back to work, I'd have to take what I call quiet time. I'd have to go in my office. I'd shut off all the lights, no interruption, just to get, my energy back, or to get my brain to recover. And I'll tell you, that's difficult because people don't understand what you're going through. If you haven't had that experience, people think, oh, Dave's back at work, everything that you're doing before. So absolutely, the more awareness that we can create, and also listening to individuals and what they're going through, is important, because it's hard to ever describe what you're going through, and then for people not to kind of understand, which they don't. It's tough. So great question. I appreciate that one.
Thank you so much, Mr. Entwistle, for great talk. Now we're going to move on to our next speaker. So I'll pass it on to Kobe.
Awesome. Thanks, Dean. And thank you, David. Really an inspiring way to start the conference with a personal story from our CEO. I think we're all very lucky to have a healthcare CEO that understands the importance of quality healthcare. So thank you. And so I want to introduce our next speaker. So in the spirit of Stanford and Silicon Valley, we will turn to the world of innovation and bioengineering. After completing his MD PhD at Cornell and during his residency training in neurosurgery at New York's Presbyterian Hospital, Dr. Ghajar invented and patented several neurosurgical devices that are currently used worldwide. He joined the neurosurgery faculty at Stanford in 2014, and he's joining us today to talk about his journey and his work. Now it's my great pleasure to introduce you all to Dr. Ghajar.
Thanks so much. David, that was an incredibly moving story. I think that it sets an example for the whole conference. So I have slides. I'm the setup guy. I'm setting up for the panel. And I want to talk a little bit about TBI, how we define it, and then split it up into coma and concussion. But before I get there, I want to thank the Synapse group. I run the concussion clinic at the Stanford Neuroscience Health Center, and also take care of the Stanford varsity athletes with concussion. We also have a level 1 trauma center at Stanford and Santa Clara Valley, which is an excellent rehab facility. So Synapse has been terrific in helping our patients who have survived a TBI and providing support to them. So I really appreciate it. You guys join us, once a month or once a quarter at the concussion meeting, and we get to hear from patients and from you, and it's really educational. So thank you very much for all the hard work you're doing. So I thought I'd talk a little bit about traumatic brain injury and how we manage it. And I want to split it up into 2 parts because it's very different management, and bring a little bit of science in, so the people that are here on the call that are interested in the science part will have something to dig into. So if you go to the next slide, before I get there, I want to thank my colleagues Angela Lumba-Brown is an ER physician. She's co-director of the Brain Performance Center at Stanford. And Odette Harris is chief of the brain injury section. She's in charge of all the severe TBIs that come into Stanford. She's also over at Palo Alto. Jerry Grant is chief of pediatric neurosurgery at Stanford, but he also runs the pediatric concussion clinics. He's involved in a number of studies in the schools around Stanford in monitoring concussion with David Camarillo in the engineering department, where they're using mouth guards. So I want to give a shout out for my colleagues at Stanford. We have an incredible group of people. We also have undergraduates that work with us at the center, and we're doing a lot of work on concussion with those people. Next. So TBI is, a lot of people don't know this, is the leading cause of death and disability in young people. And it used to be when I was in training, most of them were young people in car accidents. They weren't wearing seatbelts, had horrendous accidents and brain injuries. But now with seatbelts and better prevention, we're seeing, and also the population is aging. What we see in the ER is a lot of older people who are on blood thinners, and they fall, they hit their head, and they suffer a brain injury. You will notice in the graph there on the bottom right, the yellow line is concussion. It represents about 90% of traumatic brain injury. And it was a big increase around 2005. And that's because of the military wars in Afghanistan and Iraq, where troops of up to 30% came back with traumatic brain injury. So there was a big public awareness of concussion. And so, whereas I remember the 90s, everybody was interested in coma. And I took care of a Central Park victim in New York. And there's a lot of interest in how people end up in a coma, how they recover. And I'm also president of the Brain Trauma Foundation. We do the national guidelines for severe traumatic brain injury. There's a lot of interest in that. But now it's all about concussion. Everyone's very interested in concussion. It's a very exciting field to be in. And again, what Dave was talking about, prevention is very, very important. Next slide. So how do we divide up traumatic brain injury? And this is sort of a neurosurgical division when they come into the emergency room. And we do it really by level of consciousness. Are they awake? Are they sleepy? Or are they in coma? And coma is defined, you don't open your eyes and you don't respond to commands. Often these patients have to be intubated because they can't breathe on their own. The moderates, the stuporous patients, they don't last very long in that condition. They either wake up or they go into a coma. So it's a sort of a transient condition for the first day or two. And as I said, the vast majority, 90% of people have mild traumatic brain injury, or we call that a concussion. A lot of people say they don't like the word mild, but that's the way we did it, because when they came in the emergency room, you're either awake, sleepy, or coma. So there was mild, moderate, and severe. And it's not a very good term for people who have long-lasting problems from concussion. Next. So this is, Brain Trauma Foundation has started the first guidelines in any branch of surgery back in the 90s. And we do pre-hospital, in-hospital, adult and pediatric severe traumatic brain injury guidelines. They're guidelines about how to take care of people in the ambulance, how to take care of them in the hospital, in the ICU. They're used in every trauma center in the United States. They're also used internationally. And we had a study of the impact of these guidelines, and also the CDC has also written about it. And a chart on the right is a diagram from one of the papers in New York State showing a 45% drop in deaths when the guidelines are put into practice. A lot of the guidelines are about making sure a patient gets fluid resuscitation and gets fully resuscitated, gets brain pressure monitoring. We don't hyperventilate, we don't give steroids. And those kinds of things with intensive care led to a dramatic drop in mortality. Mortality was twice as high before. So now we're looking about a death rate if somebody comes in with severe TBI in the emergency room of about 15%. My colleagues at Cornell are working in Africa and Tanzania. They recently came up with their mortality rate. Their mortality rate there is 70%. And that's really because they don't have good pre-hospital care. They don't have the ambulance system we have here. They don't do the resuscitation we have. And there's very few neurosurgeons in Africa. It's like 1 per 10 million. So, you know, a lot of these patients can't afford getting CAT scans, can't getting operations. There's a real internationally traumatic brain injury is a leading cause of death and disability. And we need to do a better job internationally. Next. So let's switch over to concussion, because I think a lot of people are interested in this. And also, I think people who recover from severe TBI that aren't vegetative, I think David brought a great word he called brain fog. And you see that term very often. You even see from people with survivors of COVID that describe brain fog. They feel foggy, they can't think clearly, they have problems with memory and attention. I think it's a great term. But you know, I think for concussion is really being driven by the study looking at NFL brains, the Will Smith movie Concussion. And the big question for families is, should I let my 8-year-old play football? Because I don't want them being demented when they're 40 years old. And that's driven a lot of research in concussion, a lot of looking at long-term outcome and trying to find better ways to diagnose. Next. David brought this thing. I didn't know his story, but I had this slide in here before, but wearing a helmet's very important. And Stanford students, through the generosity of the Siegelman family, are given free helmets as freshmen. And I discovered after talking to the Siegelmans that they've been trying to do this for several years, and they have very good statistics that when the freshmen come in, they all wear helmets. And then about 2 weeks later, they don't wear them anymore. And the percentage of students wearing helmets on bikes on Stanford campus is about 15%. It's actually higher for medical students, and it goes up to about 70% for graduate students. So it seems like the more you're educated, the more you wear a helmet, but the freshmen don't because they see the seniors not wearing them. So we need to change that. And I think David may be able to help in that little way. The right scans is showing somebody, as a patient I had, not wearing a helmet, and you can see multiple skull fractures and all that. So helmets are really good for preventing skull fractures and scalp injuries. Unfortunately, your neck is producing most of the injuries, whipping the brain around, and that's where you get the shearing and a lot of the problems afterwards. Next. So there are a lot of technology out there for in sports, especially for detecting concussion. The mouth guard, I mentioned David Camarillo in the engineering department here at Stanford has a mouth guard with accelerometers in it, and they can see how fast people's heads are moving, accelerating, decelerating. We're hoping to catch people early on so we can say that person was subjected to a concussion force. Let's take them out and do examination on them. We're not there quite yet, but it's very hopeful. You see some of these bands around that they're not really as accurate. You really need something that's on the jaw. And of course, what we really use is see if the sports player is not behaving properly, is maybe balance problems and so on. Sideline assessments, again, we're waving our fingers around, not as good. We're using eye tracking at Pac-12. We assess patients in the sidelines using eye tracking tests. There are other tests that can be used. Blood biomarkers, very exciting in that Abbott and other people are coming out with blood biomarkers for concussions, a saliva test that recently came out. So I think we're going to see a lot more biological biomarkers for brain injury, not only in the sidelines, but in the emergency room for people with severe TBI. And we'll be able to predict maybe prognosis from that. So that's very exciting. In the clinic, especially in a concussion clinic, we have neurocognitive tests. Again, eye tracking, EEG. MRI is usually normal in people with concussions, although I'll show you some studies where we can find abnormalities. Of course, looking at balance and other things. Next. So this is the current practice for concussion management. And unfortunately, I have a lot of patients being sent to me at the clinic at Stanford who have been told not to look at screens, not to strain the brain, not to exercise, stay in a dark room and wait for your symptoms to go away. And unfortunately, it's produced an epidemic nationally of people that have anxiety, depression, are not getting better. And so a lot of it's tied into the second impact syndrome, which is true. You should try not get a second impact within a week of a concussion, but that doesn't mean you can't exercise or you can't correct impairments. And I'll drill down on that in a minute. Next. So we published this a couple of years ago, evidence-based guidelines, concussion guidelines, and it was with a group nationally recognizing that certain impairments in people with concussion, and by the way, these impairments are also seen in people recovering from severe TBI. And the main ones are vestibular, where they can't keep their balance, or eye movements, you can't follow things properly. A lot of these patients have cognitive problems, headaches, migraines, anxiety, mood, and depression. They also have two other things that can go wrong with them, which is sleep problems and a neck whiplash. So the neck is really important, produces a lot of problems similar to concussion. But with this, we are now at the Stanford Brain Performance Center organizing ways of diagnosing and treating people with concussion that may have application to people recovering from severe TBI as well. Next. So this is the type of information we give out to patients. If you go to our website for the center, you'll see vestibular, ocular, motor, cognitive problems, headache, migraine, anxiety, mood, and so on. And the reason why we recognize these subtypes is because they're treatable. We can actually treat them. We don't tell the patient, go in a dark room, wait for it to go away. No, we treat them. And so like all the varsity athletes, if they have a vestibular problem, we will start doing vestibular balance training on them and they get better quickly. Next. So I just want to put a little bit of science in there. So I wrote this paper with Rich Ivory, who's chair of psychology at Berkeley, on the predictive brain state. And I always tell my patients, your brain has a fundamental problem. It takes time to process information. So you're always in the past. And the only way the brain can interact in the present is by being in the future. You have to be predictive. In fact, the brain's a prediction machine. It's predicting all the time. I'm talking in the cadence of my voice. You're guessing when the next word's coming in because of the timing. And it's a circuit in the brain that's very vulnerable to traumatic brain injury. Next. So a lot of people don't know this, but 75% of the brain cells are actually in the cerebellum. So 75% of your neurons, all of your brain is in the cerebellum. And that's your timer. It's telling you when to synchronize information coming in with your processors, which is called attention. Next. So the theory we have that we're working on that actually has a lot of applications, severe TBI, is a disruption in prediction. It occurs because the superior cerebellar peduncle, the outflow tract of the cerebellum, is a very small wispy connection. And it's very close to the brainstem that gets sheared or gets pulled when you have a traumatic brain injury. And that can disrupt attention, balance, following things with your eyes, and can produce this state of, I don't feel like myself. I feel like in a fog because you're not orienting. Next. We just came out with this paper with Pratik Mukherjee from UCSF, who's going to be on a panel, I think tomorrow. He's a neuroradiologist there. I've been working with the last 15 years. And we did this study of MRI in athletes, varsity athletes and other athletes, showing a disruption in the superior cerebellar connection with the brain. And it occurred in athletes with concussion. Next. So some of the tests that we do for cerebellar testing are really eye movement, whether the outside world is moving, you're following with your eyes, or you're moving and trying to keep focus. Next. So what we really do to make a diagnosis is we look at you moving, looking at something we call a vestibular ocular reflex, or things are moving and you're trying to keep up with them. That could be smooth pursuit, convergence, saccades. And then we look for neck whiplash. I have a lot of people in car accidents who get rear-ended and their neck whips forward and they pull the muscle between the skull and the cervical vertebrae. And that muscle is very important. It sends lots of messages in the brain and tells the brain where the body is in space and time. And so if it gets it wrong, you can have headaches, dizziness, eye movement problems just from that. So it's very important. Those three usually produce the symptoms. Next. So these are treatments that we give patients. The optometrist does vision training. Vestibular people do balance training. The cervical physical therapists work on the neck. And then for migraine, mood, sleep problems, we have specialists we send them to. Next. Exercise is a key to recovery from concussion. And as David said, recovery even from severe TBI, getting mobilized, moving, increasing blood flow to the brain is very important. So the varsity athletes, the next day after concussion, they're all on stationary bikes getting cardio exercise. It dramatically improves recovery. Next. So I'll stop there and take any questions. Thank you for your attention.
Awesome. So if anyone has questions, feel free to type in the chat or raise your hand and we'll call on you. But until there are questions, I actually have a question. I was wondering, Dr. Ghajar, I know you've patented some devices that are being used. I was wondering if you could talk a little bit about some of these devices that you've produced.
Yeah, so I think it's really important for physicians and other people have ideas to try and patent them. It's a really interesting process. And you'll discover a lot of things. Patent law is really interesting. So when I was a resident at Cornell, New York Hospital, one of the most common procedures in neurosurgery is doing a ventriculostomy. You put a tube into the brain, try and hit the center. And I was a first-year resident in neurosurgery, and you get to pass it 3 times to see if you can do it. You make a hole in the skull, and then you pass the tube. And so, of course, I missed the first 3 times. And then the chief resident took the catheter and put it and hit it right away. And I said, "How did you do that?" Because that's why the residency is 6 years. Well, now it's 7 years, but you learn through experience. And I'm going, and I just finished my PhD, and I said, that can't be right. You got to have, there must be something. So I went back to my anatomy books and realized that the brain develops from the cerebral spinal fluid spaces and forms at right angle. So if you go at right angle, you'll hit the every time. So I made a little tripod and put a catheter through it and hit every time. And it's called the Ghajar guide. And so we use it around, but you know, some people like to just do it by hand. But I'm just saying that got patented. A company was funded by J&J. About 15 years ago, I got very interested in how people pay attention. And I realized that the eyes can only focus on a very small area. So when it moves, the brain's got to predict, which is attention. And you can actually measure attention through eye movements. So, so I did a bunch of patents on that, started a company called SyncThink, which is being the platform that the Pac-12 used and used at Harvard and Cleveland Clinic, a bunch of other hospitals and stuff. So it's a startup. I don't wish anybody a startup. It's not, a lot of people think it's very glamorous having a startup, but it's a lot of work. I just founded the company. It's off on its own, but it's a lot of work. It's a lot of fun too. But I think for solutions for patients, you just can't be in the lab and come up with something. You have to translate. You have to make something, get out there, and you have to commercialize it. So whether it's a pharma drug or it's a device or software, AI is big right now. It's very important to get out there and translate. Stanford is really a tremendous, that's why I came here actually, is to Stanford with tech industry around here. It's just an incredible environment for really making a difference, because that's what we're focused on, is at the end of the day, making a difference in patient lives. And you have to do it multiple ways. A nonprofit like a foundation, or it's a hospital, or it's a company. Takes a village to come up with a solution.
Fantastic. I'm actually getting a lot of questions direct message to me, so let's take a look here. So, okay, I have kind of a clinical question. Someone's asking, how do you get aerobic exercise when you also have chronic fatigue or pituitary deficiency?
Yeah, so if you have chronic fatigue syndrome, it's a real problem, because what happens is there's sort of an energy envelope around people with chronic fatigue syndrome, where they exercise, and a lot of times they exercise, they feel quite good, but then hours later or the next day, they feel absolutely horrible, and it dissuades them from exercise. So in those people, some kind of graded exercise is good, or stay within the envelope. but I think it's very important to do it. A lot of people who do exercise get dizzy. And so what we do is a stationary bike because you don't move your head, so you can finish the exercise. But for people with chronic fatigue, it can be a problem. It's really, I had a patient yesterday, had chronic fatigue syndrome, and I was telling her she's got to exercise, and she says, I can't, because every time I exercise, I'm bed bound for the next 3 days. So it is a problem for that group of people.
Maybe something for Silicon Valley to tackle.
There we are. I mean, well, a lot of, I think chronic fatigue syndrome, and there's a lot of syndromes that have these labels that don't really do much for a patient. They label them and they walk away. And so the question is, can we do better diagnostics and treatments? It's probably an inflammatory response. So you get that for Lyme's disease and for post-concussion. They all look very, David brought up brain fog. And I think that's a very good term. We're seeing in the Havana syndrome, the embassy employees who are in Cuba and China who have brain fog, or COVID recoverers. It's sort of it's a late response, inflammatory. What's going on? How can we treat it? It's a big concern for post-concussion. There's about anywhere from 5 to 30% of people, depending on pre-morbid issues, they have these long-term problems. I don't want to get too much away from the panel. The panels, you have some real experts there, both in severe TBI and concussion, and I don't want to take questions away from them. They're a lot smarter than me on some of these questions.
We're actually still waiting on one panelist, so.
Okay, all right, go for it.
If I could take a couple questions that would be good for you in particular. If someone's asking about TBS, how do you feel about TBS for TBI? Someone did it as a case study at Stanford, and they think that you might know about it.
DBS, transmagnetic stimulation so that's been very effective for depression. So a lot of people have used, so it's a magnetic stimulation of the brain, usually the dorsolateral prefrontal cortex. What they do is they stimulate it and the brain gets stimulated. And a lot of people with depression can find relief of that. So it has been used in TBI. I haven't seen really good studies on it yet. But again, I would try the usual stuff. And if that doesn't work, then go to some of these other ones. I mean, there's a whole host of treatments out there, which, for instance, people say, should I take fish oil? Should I do hyperbaric oxygen? Should I just do brain stimulation? And I said, have you tried seeing if your balance is normal, or have you tried a little bit of exercise? And, they don't do the basic stuff. So I would start with basic. And then if that doesn't work out, then go to these more high-end things. I think there's a lot of potential solutions out there that may work in some people and may not work in others. And so, but I would try the basic stuff first. I mean, the basic function of the brain to be oriented to the outside world. And if you're not oriented, it means you can't pay attention. So it's your window on the world. And, we can assess that and treat it. So more and more of the technology around assessing concussions or brain fog really have to do with attention, which is, I consider attention is so a lot of people think, well, attention is the brain. It's actually, no, it's a separate process from processing. There's two things going on. You select information, time and space, and then you process it. So you can have a lousy attention, but really good processors. And you see that sometimes in kids with ADHD or some people with attention problems, they figure out ways around it. And the human brain's adaptable. If you have a problem, you try and work around it. And so for some people, it doesn't work out. So there's a lot of treatments out there. I would try the usual things first. And if they don't work, then try it out.
Awesome. Well, we have a lot more questions in the chat, but I wonder if I can direct them, Dr. Ghajar, to contact you directly after, so that we can move on to the.
Sure. Or address them to the panel. Sure.
Yeah, that's a good point. there will also be a Q&A session with the panel, which Dr. Ghajar will be a part of. So if you guys have additional questions that you'd like to ask the doctors, maybe let's hold those questions till then, and you can always reach out afterwards. So without further ado, let's get started with the panel. Does anyone on my, let me see if I can find this. There we go. Fantastic. Okay. Actually, does someone on my team have this that can present it so I can look at the text as well? If not, I can manage. Let's see what I can do here. Okay. So now we're moving on to a panel, which Dr. Ghajar is going to be a part of. And we're also being joined by two other physicians. So I introduced Dr. Ghajar earlier. Let me give a brief introduction to our new panelists. So first we have Dr. Angela Lumba-Brown, who's an academic pediatric emergency medicine physician with experience or expertise rather in neuroscience and neurocritical emergencies. She's been an instrumental part of our conferences in the past, and she's a national expert on traumatic brain injury who's led several recent large guideline projects. She is also the co-director of the Stanford Brain Performance Center, where she works to advance the neuroscience of brain synchronization in childhood development, injury, and aging through novel biomarker discovery and treatments. And we're also joined here today by Dr. Neil Schwartz, who joined the Stanford Stroke Center in 2004 as a fellow in vascular neurology and has remained on as a faculty member since 2007. His current primary focus is on the care of patients with cerebrovascular disease in both the inpatient and outpatient setting. And he has a particular interest and expertise in cervical artery dissection, non-atherosclerotic vasculopathies, and stroke in young adults. And he's a national leader in neurological education and served as the program director for the Stanford Neurology Residency Program for nearly a decade. And he is currently the director of the newly launched Young Stroke Program within the Stanford Stroke Center. So thank you all for joining us today. Since Dr. Ghajar has spoken a little bit, I thought maybe we would start with each of you with a kind of a brief introduction. Tell us kind of about your journey. This is a career panel, so we have people that are interested in hearing more about your careers. So anything you have to share in terms of your journey, just kind of a brief story. So Dr. Lumba-Brown, would you like to get us started?
Toby, thanks for having me here today. Can you hear me all right?
Yeah, thank you for being here.
Great. Can you tell me a little bit about who's in our audience tonight?
Yeah, so we have a mix of folks. The audience for today should be primarily the Stanford undergraduate community, but we've really advertised broadly. So there may be people kind of across the institution. We also likely have individuals from our peer support group. So there's probably brain injury patients in the audience as well. But I think the career panels is really focused towards taking a look at what it's like to have a career in the field.
Wonderful, thank you. You know, when I look back at myself in high school and as an undergraduate student, I knew that the brain and how it worked was very interesting to me. I even dressed up as a neurosurgeon for Halloween one year. I know Dr. Ghajar is going to love that. I'll show you a picture sometime.
Yeah.
But, you know, I wasn't sure, you know, at that stage in my life, if that was the future for me, where it would take me. I had many things that I was interested in. I loved to write. I loved art. I loved taking care of people. And you know, we find that those things that we're drawn to when we're young, when we're in high school, when we're in college, when we're moving on to the next stages of our career, often have repeated patterns as we go through life, so that many of the things that we were interested in when we're in our teens, we're still interested in when we're in our 40s or 50s or 60s. And it's really nice to be older now and be able to reflect back and say, hey, neuroscience was always a theme in my life, and little things continue to build on it. So through undergraduate work, I studied neuroscience as an elective. I took behavior classes as electives, because out of pure interest, not with a specific plan in mind. And know if I did have that specific plan, it would have even been, a better foundation for me. So something to always think about along the way. And then going through medical school, I really enjoyed any aspect of cognition and anything related to brain injury and how that affected the person. I was fascinated by development in children. And I decided that the next best step for me was to continue caring for children as the patient population that I was going to serve. So I didn't focus specifically on my deep interest in neuroscience, but on the particular type of patients that I wanted to take care of. Moving through medical school, residency, and fellowship, neuroscience continued to be an important topic to me. And I really focused at that point on patients who had sustained traumatic brain injuries, so had been struck in the head and either had a mild traumatic brain injury, which we often call concussion, or more serious forms of brain injury. I began doing research. I connected with other people who had similar ideas that I did. A seminal connection for me was with the Centers for Disease Control in my fellowship, where I began a long relationship with them in researching traumatic brain injury. And then as new jobs actually came about, I sought out those people who had similar interests as mine, and I wasn't afraid to do so. I wasn't afraid to email Dr. Ghajar and say, hey, I'm new at Stanford and you like traumatic brain injury and I like traumatic brain injury. We both want to help these patients. Let's meet up and talk about it. And so it's really having that drive to go and seek out people who you might collaborate with, who might mentor you, who might work with you in other areas, or be there to discuss a difficult challenge that you have through your career, are important aspects to remember along your path as you move. I suspect many of you will move into some sort of clinical or healthcare path. So it's important to seek out those people who share the same interests as you and the same passions in helping other people in the area that you're focused on. And that's what I did.
Awesome. Really great points. And yeah, it's a testament to just following your passions and following your bliss and ending up where you're meant to be. So great story. Dr. Schwartz, would you like to share a little bit about kind of how you arrived at your current position and the things that you explored along the way?
Absolutely. So you guys, thank you so much for inviting me. This seems like an awesome conference. So I am not a TBI expert, although kind of dabble a little bit in TBI. And I know this is a clinical panel, but I just wanted to reflect on something Jam was saying about, there are some kind of novel things out there, on the horizon in terms of treatments for TBI, but, best to just sort of start with, tried and true principles. But we did complete a really interesting trial here on using stem cells in traumatic brain injury. Dr. Gary Steinberg, who's one of the neurosurgeons here, was the neurology or the neurosurgeon PI, and I was the neurology PI. And incredibly, the trial was actually positive, and we were looking at motor recovery in patients with TBI. And so, usually TBI is sort of more of a global insult, and we certainly see a lot of that, but we do see some patients that develop, kind of a focal area of injury in the brain and have weakness on one side of their body. And that was what the trial was targeted towards. And it actually had positive results. We were working with a Japanese company called Sanbio, and it may be a treatment that is on the horizon. There may be some things that we can do even years after injury to help kind of jumpstart recovery of some of these circuits in the brain. But anyways, in terms of career paths, I guess I'll start by saying I absolutely love being a physician. I love what I do. I've been at Stanford for 20 years, and I love coming to work every day. And those of you who are, pre-meds and, not sure you want to do this, or somebody told you, oh, it's not great, obviously follow your heart, but I would absolutely encourage anybody who has an inkling to go into medicine. And it's an absolute privilege to be able to do what we do every day. So I got interested in the brain when I was an undergrad as well, and was doing some neuroscience research, and actually really liked that. Still thought that I was going to go into medical school because that was a very early interest, but thought I wanted to do some research as well. And so I ended up doing a combined degree program at Northwestern University, actually in Chicago. And it was there that I decided I was going to be a neurosurgeon. That was the plan. And I worked with some pretty awesome neurosurgeons in Chicago, and it was getting close to my 4th year. And it just kind of, it hit me one day like a ton of bricks that I hated the spine. And it was indeed, I think it was spine surgery that and some other things that really killed neurosurgery for me. But I always really, there's a lot of overlap, between our two fields, and we both, have similar interests and really a love and passion for the brain. And so I ended up going into neurology. I had studied circuits, and that was kind of my background, was in electrophysiology. And so I was sure I was going to be an epilepsy doctor when I started my neurology residency. But then I got really excited about what was happening at the time in vascular neurology, or stroke, which is what I ended up going into. And stroke is actually a really interesting area of medicine because it's something that is incredibly common, and I overlap with cardiology and hematology and infectious disease and the surgical specialties and rehab and even OB-GYN. So it's I get to do kind of a lot of different areas of medicine, but also get to be a neurologist as well. And I think one of the things that I was always attracted to acute medicine, like you might see in the emergency room or that neurosurgeons deal with. And so I really liked, dealing with patients in that setting. And it really is a privilege to, be with patients. Many times, patients and their families on the worst day of their lives, and when you're dealing with, severe brain injury, you're really dealing with, the worst thing that can happen to the most important thing. And so, this is pretty weighty stuff. And so I kind of enjoyed that. But then also, it is nice to, I do have an outpatient practice as well. And it is nice to see patients in clinic and, to see how to build these longitudinal relationships and to see how they recover from stroke. And then of course, all of us are in academics because, we love, teaching and being with the students and being with the residents and the fellows. And also academia kind of allows you a lot of freedom to pursue other things, whether it's, innovating in medical devices or doing global health or policy or, anything like that. And once you leave, the confines of academia, you don't have that many options. So I love my job. I love what I do. And I wish all of you guys good luck in your own career pursuits.
Awesome. Thank you for that, Dr. Schwartz. And Dr. Ghajar, you talked a lot about brain injury, but do you want to spend a couple minutes talking about your career path and what led you to your current position?
Yeah, like Neil, I did an MD PhD. I did undergraduate, I did neuroscience research like he did. And I was I got the reverse story, Neil. I was, when I was at Cornell, I was actually, my PhD was under Dr. Fred Plum.
Oh, yes.
A very famous neurologist who wrote a book called Stupor and Coma. And I did my PhD in brain metabolism, blood flow. I took a tiny part of the puzzle of that. And I was gonna become a neurologist. Actually I was, at that time, it was before the revolution in Iran, and they were building a new medical center it's another story. Harvard, Columbia, and Cornell were building a medical center in Tehran that was called the Imperial Medical Center of Iran, IMCI. And I used to go back every summer and get students to try and come over there and become part of the hospital. They left those letters there after the revolution because they changed it from imperial to Islamic. And so they didn't have to change the letters. But anyway, I was going to become a neurologist. And then I just liked neurosurgery. And I sort of agree with Neil on the spine stuff, but there's neurosurgery is like you go and you make such a huge difference in somebody's life right away. So it's kind of good for people who, that like to see solutions quickly. And I did a lot of surgery when I was doing my PhD. So I like working on my hands. I like the eye-hand coordination. I like the judgment you have to have. You have to, a lot of neurosurgery is my thing is not this. It's your judgment. It's picking the right patient to operate on. A lot of people, Hollywood makes this sort of dramatic thing that they have these incredible fingers and hands, and you share your hands. It's not. It's about your brain. It's about making the right judgment, picking the right patient, and doing the right thing. So it's a great field. You can make a lot of difference in people's lives. Very exciting. I think neuroscience in general is a really exciting frontier right now, and there are a lot of changes. I think that Gary Steinberg's work on stem cells is extremely exciting. It has a lot of potential, not only for people who have movement problems, but other things as well. So it's a very, it's this whole idea that the brain's being suppressed after an injury and that you can release it with these stem cells, which is very exciting. So I think it's going to be, and of course, stroke is, made incredible advances. We used to do all our aneurysms openly, and then we did interventional. So it's all changed. So I think it's a very exciting area to go into. I think I would highly encourage students to pursue it. It's a long road, so you have to be really interested in it. But yeah, highly encourage it.
Awesome.
Yeah, it's, for sure. And, for most of you guys, you're sort of at the beginning, and it seems kind of daunting thinking, you do the math of, well, okay, I'm going to be this old when I finish undergrad and this old when I finish med school. And then this residency is this long and this fellowship's that long. And yeah, I mean, I didn't actually have a job really until I was about 40, but, it's sort of the journey along the way. And, obviously it's fun to, make money and be able to get stuff, but really, all along the way, you sort of enjoy the different aspects of training, and I wouldn't be in a huge rush.
It's actually very comforting because I've done the math, and I will be in a similar timeline as that, starting a career around 40. So
yeah, you'll have plenty of years to work.
Yeah. I'm excited. I'm looking forward to it.
Well, the main thing is you're making a huge difference in other people's lives. That's the thing. It's a privilege. Actually, I would say, it's a privilege being a doctor because you can help people. You have the power to help people. And I think that it's a privilege. And if you can get in there and get that privilege, then you should go for it. It's very satisfying to help people.
Couldn't agree more. Oh, sorry.
I think there's, I used to do that too. I used to say, oh, how old am I going to be if I decide to do this fellowship? And, should I just decide to do residency and go on from there? In the end, there's really no math to do, right? Because we're all on the same journey through life. And if we're thinking about a goal at the end, my goal is to be a fellow or to be an attending physician. Okay, well then what happens when you actually get there? Or those previous years are not negated, right? So I think once you decide that one of your passions is to care for people, or one of your interests is relevant to this conference is in neuroscience or traumatic brain injury, well, your work has started, right? Your work has already started. And for many of the volunteers that work with Synapse to lead groups and talk with patients, your work has already begun. And so, sure, you might not be getting paid for it with money, but you are learning at the same time, and you are building connections and helping people. And that's really why we're going into it. Because if you're going into it for anything other than that, then you should double think about that, right? You should really reconsider if that is your end goal. Then perhaps becoming a clinician is not the best role for you. But I know for many of you who I've talked to personally, who I see in the audience here, connecting with patients, connecting with other people who might have also had brain injury as you have had, is special and is important. And you're giving something of yourself to that person. You're learning, you're teaching them as well. And so that you're already on your path.
Thank you for those
One
wise words.
thing you may want to bring up with the audience, because there's a lot of TBI survivors there as well as students, is this idea that I notice a lot with people who've recovered from severe TBI, is I would call it the dissonance of self. So you're a different person afterwards, right? And no judgment, you're just a different person. You had a brain injury and then you're different. Of course, you're different when you age too, but it's slow, but it's a sudden difference. And so the sudden difference, when people compare themselves to what they were like before the injury, and they compare, I call it the dissonance of self. And oftentimes and then the family and friends, it'd be interesting to see the audience, what kind of response they have to this. But the family and friends sort of remind them of what they were like before. And it can produce, a dissonance because you're different. And I think the acceptance of the person, of who they are now, is a very important part of adjusting, or I wouldn't even call it adjusting. You're a different person, right? Be interesting to hear from the audience what their take on that is, because I see that, and I think a lot of the problems of depression or things like that are because of this difference of before and after, and then being in an environment where it's always contrasted. I don't know if Angela or Neil, you've seen that in any of your stroke patients, for instance. How do you deal with that?
Yeah. Yeah, it gets a little bit philosophical in the sense that, the way we construct our kind of mental models internally, probably the way we, remember a lot of things, probably even the way we sort of construct time has to do with language. And we sort of are thinking in words, primarily. And so it is interesting, particularly a lot of patients with aphasia, which is a language problem, and it usually comes from, injury to the left hemisphere. I think there are some really fundamental changes in sort of who they are and kind of their concept of self and how they kind of put together their models of the world. But yeah, it is interesting how to deal with that. I would say that in general, people are incredibly adaptable, and even people who sort of somehow do become new people in some respects, kind of this dissonance you're talking about, Jam, they do seem to adjust, maybe the things that they wouldn't have liked before, just sitting, watching the birds or something, then become, interesting, or that, they're sort of passionate about. And well, that's just the thing that their new self likes. And that's, something that everybody should validate and hopefully doesn't cause them distress. But yeah, it's an interesting problem for sure.
We do have some comments in the chat.
Sure, throw them out.
Yeah, I would love to invite the audience to engage.
Sure.
I have a comment about family and friends do not adjust as well as survivors sometimes. It's an interesting point. The survivors are actually adapting faster than the people around them. Someone says, where does the problem stem from in the brain if the eyes move by themselves at times when you are reading, not tracking well?
So yeah, so they're really, if you look at eye movement, it's many parts of the brains are involved. From the cortex, they call the frontal eye fields, and the back part of the brain that has vision, and then the brainstem. So it's a multiple areas that are involved with eye movement, and because of that, there are different kinds of eye movements that can be abnormal. And I think most people are using it because obviously a lot of people think that recognize the brain as being the center of cognition, but to cogitate you have to pay attention, and a lot of that requires multiple areas of the brain working together. And with certain eye movements, there are multiple areas that can be affected that similarly affect cognition. So you might see similarities between the two. But reading is one of the most common ones. Actually, there's a test called the King-Devic that you read cards and they time you, and if you make mistakes, then you're failing the test and so on. So a lot of people after concussion, or even people after traumatic brain injury, have trouble reading because they've got to read a certain way, and their eyes don't move the right way, and then they have to reread the line, and so it's a very common issue, not only for traumatic brain injury, but for kids with ADHD or dyslexia, or it's a common. And I think we're also stuck in, that might be a topic for the panelists, stuck in the world of labels, right? So what's your label? Oh, I've got a chronic fatigue syndrome, I've got traumatic brain injury, I've got concussion. Those are useful labels if you can identify impairments, but a lot of times we're putting labels on people and we're not, what are we doing about it? So I think it's important to figure out if you have an impairment, try and correct it, and then who cares about what the label. Sometimes I have people with concussions coming to me and saying, it's a year or two out, I've got this problem. Is it from the concussion? And I'm saying, who cares? If you have an impairment, let's correct it. And so I know it's a little bit flippant, but I do think it's important to not get stuck on a label. I am this. It's more important to say, what's the problem? Can I correct it? And then go from there. And then, I think there's too many labels, especially unfortunately in neuroscience, that are not useful labels. A label should be prognostic, diagnostic, lead to therapies, but many of these labels are just, the subjective. Some people may have it, some people may not, but it is a unifying thing. The brain only can focus on one thing at a time. So you say, I have this syndrome. Well, it can be useful if it really points to things that can help you out. But at the end of the day, you want to get better. You want to be all that you can be. And so that's where you want to aim for. So finding out what the impairments are is really important.
Well, we're running pretty short on time, so I'm going to ask 2 more questions. So James first has a question. Is it possible to recognize undiagnosed concussion symptoms long after the fact? For example, in someone who plays high school or college football, decades before our current awareness and attention to concussion injuries.
Angela, you want to take that, or you?
Sure. Yeah, symptoms following concussion are often called post-concussive symptoms, and certainly they might not be recognized in the first day or even days after injury. It might be hard for that person to put a word to what exactly they're feeling because the symptoms can be very nonspecific, like feeling like you have a brain fog or you're just not yourself. But for the most part, following an injury, if there is something, if there truly is an injury, you will, in a short period of time, within a week, notice something is off. You'll notice maybe your sleep is disrupted, that you're having headaches more than you usually do, that you're feeling more anxious. Maybe you'll have nausea that comes and goes in the day. Now, months and months later, while there certainly can be sequelae secondary to an injury, it is not common for that to occur if the person had the injury and didn't even know that they were injured thereafter. Was that the question? If you don't even know you have an injury and then months later, can you present with it?
Yeah.
I suspect that this question is also getting towards CTE, which is a repetitive, essentially the result of repetitive head injuries that we see often in elite athletes, say as in football players who have had long histories of hard body hits that resulted in mild traumatic brain injuries, or direct blows to the head that resulted in mild traumatic brain injuries. And certainly then, this is a whole other entity of injury and chronic abuse to the brain that does result in changes in cognition, behavior, and emotionality. But it would be really unlikely for someone to, say, have played football and known they had taken many hits and then years later have this symptomatology relevant to CTE and say, oh, how did this happen? Because I never actually had a concussion. You would have remembered having multiple concussions through your history. So that would be very, very unusual for that to happen.
Awesome, thank you for that answer. It looks like our audience member that had a question left, but we are already over time. So I'm sure I speak on behalf of all of Synapse when I say that we're super grateful to have you guys here. You guys have all been wells of wisdom, and we really appreciate you taking the time to talk with us and share your perspectives. Yeah, and so with that, thank you so much. I'm going to close us out. Or Gabby, or actually, no, sorry. Zoha will be sharing some closing thoughts.
Thank you, Kobe.
Thank you, Kobe. Thank you to all of our speakers for your time and wisdom, and thank you so much to everyone who attended. We really loved seeing your enthusiasm in the audience. And just a reminder, if you haven't already, please fill out the attendance form. You can find it in the chat, and if you can't find it, we can send it out again. And tomorrow we'll be hosting our policy-oriented day of the conference. It is going to start at 3:30 p.m. Pacific time with a talk by Dr. Kim Gorgens. She is a neuropsychologist at the University of Denver, and she'll be speaking about brain injuries in the criminal justice system. She's an amazing speaker and an advocate, and she has presented her work at numerous conferences and at TED Talks, as well as for CNN and for NPR. Following that will be a talk by Gray Farley, who is a Stanford undergraduate student, about reducing brain injuries in sports. And then we will have Ken Collins, who is an advocate of developing home and community-based services for people with brain injuries. And he's done amazing work for the TBI community. And finally, we will have a speaker we recently added to our lineup, Amanda Burrell, who is a veteran and a brain injury survivor and advocate. So we really, really hope for it to be an exciting day. And if you have any questions, feel free to stick around. Otherwise, thank you so much, everyone, for coming, and have a great evening.